Okay, this week in Module 2, we'll be discussing oral motor and feeding issues and vocal and phonological development. So primarily, we'll start with oral motor and feeding issues in the NICU. Approximately 12% of infants begin life in the neonatal intensive care unit, or NICU for short. Now, it's important to realize that NICU practice is very highly specialized and usually requires additional training, usually on-the-job training provided by the hospital. The hospitals vary in their specifications about what type of training you need as an SLP to participate in the NICU, but just be aware if it's just something that you are interested in, there's additional training that you would probably need to receive once you were within that facility. So in the NICU, often therapy goals are secondary to keeping the infant physiologically stable because these children are very fragile, medically speaking, that we're not so much there for therapy as more as we are for counseling and guidance and evaluation specifically of the oral feeding mechanisms and helping to make that determination about when a child is ready for oral feeding purposes. The ability to take nutrition orally is one criteria for discharge from the NICU, so we play a very vital role within this position. But it's always going to be one of the end goals. One of the last things that's happening in the NICU is the taking nutrition orally rather than one of the initial, where you're involved initially with the child. Evaluation for this involves chart review and bedside feeding evaluation. For the chart review, you want to do an adjusted gestational age. So if a child was born at 32 weeks gestation and they are 4 weeks old in the NICU, then they are 36 weeks gestation. They're not actually 4 weeks old. So you want to adjust and take into consideration how old they are based on that. You want to review if they had excess amniotic fluid at delivery, which could signal excuse me, a lack of intrauterine sucking and swallowing. And so they are, whenever they're in vitro, they actually do produce sucking and swallowing. It's involuntary movements. So if they had excess amniotic fluid, then that could have been a hindrance for them to be able to do that when they were in utero. You will want to note the type and duration of intubation, if intubation was there, any types of respiratory disorders, because we know the breathing will directly impact the swallowing mechanism, and then degree of family involvement, just as we discussed last week about what the educational level of the parents, how much they're involved, what their role is in this capacity, because everything is done with, remember, the child and the parent involved. So the NICU assessment, the bedside feeding evaluation, you want to observe the infant's behavior or state during feeding. You also want to take note of the effects of the environmental stimuli on feeding behavior. And you want to note any vocalizations, airway noises during feeding. And you are looking for specific reflex patterns. So the reflexive patterns for swallowing, and I'm reading from the book here because this is not an area which I'm familiar with working. The suckling pattern. This is a primitive form of sucking that includes extension and retraction of the tongue, as well as up and down jaw movements and loose closure of the lips. And even James still, whenever he's sleeping, you can see him suckling in his sleep. Now, sucking is a more mature pattern where they're actually taking in substance by a more forceful. So it's a more mature pattern, differs from suckling in that more intraoral negative pressure is generated. The tongue tip is elevated rather than extended and retracted, and lip approximation is firmer, and jaw movement is more rhythmic. And I've posted some videos of James that you can watch, and you can see that he actually has an open bite mouth posturing right now, and his tongue tip protrudes a good bit. He actually has the short frenulum that's possibly will need to be clipped when he gets older and needs to produce that R sound, because I have seen it impact students before, but right now, because it didn't impact his sucking or his latching on for feeding purposes, we chose not to clip his tongue at the time. But the suckling, and I can even tell it when I'm feeding him because I'm still breastfeeding him, and he starts suckling, his lips are going up and down, but there's no suction there. There's nothing pulling back to actually pull the milk in. And that's when you say that they're using the nipple for the pacifier, and he does do that sometimes, particularly when he's falling asleep after nursing. So roosing causes the infant to turn the head toward the source of tactile stimulation, such as gentle rubbing of the lips or lower cheeks. So you stroke the cheek, the lips right here, and the infant will turn towards that. And so if you're breastfeeding, you might take the breast and the nipple and rub that nipple along the child's mouth, down the side or along the cheeks to try to stimulate them into feeding. You have to do this a lot when they're newborns because they have a tendency to sleep so much, and this is just typical of developing babies. And thankfully, I have very recent firsthand experience with this, so I'm a good resource for providing what this actually looks like in real life. And James is funny. None of my other children have done this, but rooting at night in the bed, he'll start rooting around by moving his head back and forth like this. The head just goes back and forth, looking for a nipple. And so if I pick him up when it's close to feeding time and he gets on my shoulder, you can see his head shaking back and forth, and that mouth just going rooting. So it's funny when he does it to people where he can't get milk. They're like, okay, you need your mom now. But it's reflexive. It's natural. They're doing it from birth practically. And then finally, the last reflexive thing is phasic bite reflex. When teeth or gums are stimulated, usually by placement of the bottle or nipple in the mouth, the baby exhibits a rhythmic bite and release pattern that can be observed as a series of small jaw openings and closings. And James does this a lot, and he'll gnaw on things. He'll even gnaw on his passy like that with the jaws. You can hear it. I'll be driving down the road, and I just hear that phasic bite reflex, him gnawing on things. So those are the reflexive patterns that we're looking for. So presence or absence of reflexes determines the need for further assessment and development of feeding plans. So if any of these reflexes are not there, then you need further assessment. You can use a developmental evaluation to determine if an infant is ready for nipple feeding, and the indications here on box 6.1. You want gestational age at least 35 to 37 weeks, severity of medical conditions, respiratory diseases would result in delay of oral feeding. Respiratory or cardiovascular stability, if they don't have stability in those two areas, then that could delay oral feeding as well. Motoric stability, do they have head motoric stability? And if not, what do you do to help improve that? Coordination of the sucking, swallowing, and breathing. Behavioral state of organization. Infant must be able to maintain an alert state. So again, when they're very newborn, they tend to sleep a lot. So it can be very difficult to get infants to rouse enough to feed orally. And then demonstration of hunger. Exhibits rooting, may exhibit non-nutritive sucking, and crying may be weak. So that's just some of the developmental evaluation that you can do to see if they're ready for nipple feeding. And this is whether they're breastfed or whether they're bottle fed. Informal interviews can be used to gather data about feeding and oral skills, and you get that from the parents, of course. You collect information from the parents and even nurses within the NICU facility. But you need to keep in mind that any neonatal fetal assessment that you use is standardized, that you need to take that interpretation with caution, because they are not always consistent or valid measures. Really, those informal measures seem to be more valid measures for determining whether an infant is ready for oral feeding or not. And then gastroesophageal reflux, or GERD for short, can seriously interfere with nutritional intake and desire to eat by mouth. If they have a serious GERD where they're always spitting up, they're always everything's coming back up, they don't want to eat. And I know I've had friends whose children's GERD was so severe, they never took a bottle, they only took the breast, they went straight from breast to sippy cup, and the child cried every single evening. I mean, they appear colicky because they're crying so much because they're so uncomfortable. My nephew had it, my children have had GERD, but not to that extent of severity. And you can usually see this, that they spit up after every meal excessively, and projectile spit up. So it's very, very common. There's a simple medication that you give a child to help reduce the reflux, and it has to just do with all the development of the process and how as they're growing. But it can, if for serious GERD, if every time that they eat, it just sits on the top of their esophageal area and doesn't proceed to go down into their stomach, they get very uncomfortable, and they don't want to take anything orally because of the discomfort that they're experiencing. So oral, motor, and feeding issues in the NICU, the management of these. All right, so the results of the oral feeding assessment yields information to determine if feeding therapy is needed. Sometimes oral feeding may not be an option and tube feeding is required. So if and box 6.2 does give you some indications of questions for informal assessment of feeding and oral skills. Who's the feeder? What positions have you tried for feeding? That's the questions that you would ask of the parent or caregiver that's within the baby's environment. All right, so management of the NICU. Results of the feeding oral assessment. Sometimes oral feeding may not be an option and tube feeding is required. So your role as an SLP should be to be familiar with various forms of tube feeding and helping parents and counseling them about when that decision should be made and what the best decision is for their child. One of the most common, the nasogastric or NG tube, that's inserted through the nose. It descends down the pharynx into the stomach. The oral gastric or gavage tube, inserted through the mouth. And the nasojejunal tube, inserted into the second part of the intestine. But all of these tubes can lead to hypersensitivity of the oral cavity because they're all there in the mouth or in the mouth area, and so that feels very uncomfortable for the baby. So if they have that oral sensitivity developed, then they're not going to be as receptive to oral feeding initially. The final type of tube that it discusses is the gastrostomy or G tube. This is the most invasive because it does require surgery. So there is a surgical risk for these babies who are already fragile and unstable, potentially physiologically speaking. So the G tube brings food directly into the stomach and frees the oral cavity. Used when the tube feeding is required for extended time. So usually if the tube feeding is going to be required for more than a month, they'll opt for the G tube because it doesn't give them that oral sensitivity that the other tubes do. But again, there's higher risk because it is surgical, and these are usually used with the most medically severe and fragile children who cannot orally intake food. So infants with non-oral feeding for extended time may show decreased sucking and oral motor development. So if that's the case, we want to be sure to counsel the parents and staff for the baby to have opportunities for non-nutritive sucking and oral stimulation. And you saw this in the Arvidsson article that was within your module that I hope that you should have read by now. So non-nutritive sucking has proven to be beneficial to help babies essentially begin oral feeding at an earlier time, more closely related to their gestational age calculation. So they're born at 35 weeks gestation. They are not doing oral feeding until about 38 weeks gestation, and maybe by 40 or 42 weeks of gestation, they're starting to tube feed, which is like a baby who's born at 40 weeks and not tube feed. They're starting to oral feed because that's like a newborn at 40 weeks. They start feeding right away. Versus if you don't do that non-nutritive sucking, then they're not necessarily going to do oral feeding as early as the children who do receive the non-nutritive sucking and oral stimulation. So they've shown that the NNS helps strengthen sucking reflex. It helps baby to learn to associate sucking with feeling content. So pacifiers or non-nutritive sucking types of options. Other oral stimulation such as stroking the cheek, the lips, the gum helps the child ready for oral feeding. You want to encourage family to ask for supplementary oral feedings as well. So when you ask for supplementary oral feedings, that means that they're getting the primary nutrition through the tube, but they're also getting a supplementary feeding to help introduce that oral feeding to them so that maybe they will be more receptive to it when it comes time to move from tube feeding into oral feeding as their primary nutritive intake. So that is our role in regards to tube feeding. I was going to see, there was something else I wanted to say about the non-nutritive sucking. Mostly a pacifier. And I have had, all of my children have taken pacifiers. Cecile is a very oral stimulation, oral sensitive child. She definitely needed that sucking and was constantly looking for it. James is kind of following similar to her, that he likes the passy. He sucks on it. He gets that contentment from it. So there's not anything negative shown with the pacifier use in the first year of life. The negative effects and outcomes come later whenever they have moved on to other feedings besides nipple feedings, but they're still using the pacifier, and then it starts interfering with their teeth development as well. But I have children who don't get teeth until 9 or 10 months anyway, so it's usually a non-issue for us. All right, oral feeding and therapy in the NICU. So as an SLP, you can work with nurses to help mothers maintain their milk supply, and this is very critical. I can tell you as a mom of completely healthy infants and newborns that breastfeeding initially is a great challenge, and it's of course easier with every child that I've had. But initially, it took Kennedy about 2 weeks before she had a good latch, and we really got the breastfeeding down pat. And so you can imagine if you're already in a stressful environment, that your child's not even home with you and you're in a NICU environment every day, and you're trying to maintain your milk and you're trying to get your baby to feed through this method, how stressful it can be. And that does not help with breastfeeding and your milk production. So you as the SLP work with those nurses, work with those moms to help them in strategies to keep their milk supply up, if that's what they choose. Now, some mothers are going to be adamant, they have to breastfeed, have to breastfeed, have to breastfeed, and then for some reason they can't. Some are going to be indifferent either way, whatever's best for their children. Some are not even going to try breastfeeding and go straight to formula. So it really is going to vary depending on the individual families. But if you do have somebody wanting to breastfeed who is in the NICU, that's just even more challenge than you would have for someone who's just breastfeeding with a baby at home who didn't have these physiological challenges that NICU babies have. So you want to encourage mothers to hold the baby skin to skin during non-oral feedings and non-nutritive sucking experiences. So if they have that capacity, they're holding them skin to skin. It's basically like breast to baby, chest to baby, getting that experience, especially if they are breastfeeding. They can get the smell of the milk, the smell of the mother, become familiar with that. That's very important for babies to have and feel comfortable. The SLP can help with positioning. You have the football hold. So you hold them like this. That can be more conducive. So typically we're holding babies like this with the head here and you're feeding on this side. But a football hold is where you take the head of the baby to the breast right here and the legs are in this direction. So that just makes it a little bit easier for the baby to latch on and for the baby to be able to suck. And I always do this hold in the bed because we're both asleep or he's asleep and I don't want him to wake up completely, so that because if he wakes up completely, then you have to start all over with putting him to bed. So that's usually whenever I utilize that position, because it's just laying right next to me, skin to skin, and it's the easiest way to latch on. It seems to be his favorite position as well for that nighttime feeding. You can help support mothers who wish to breastfeed, but also counsel that formula is adequate as well. So sometimes they're just not going to be able to keep their milk up or produce the milk that's adequate. These children might need other nutritional supplements because they're not oral feeding. So it's important to be much of a counselor here as you are the professional when it comes to these mothers, because they're already in stressful situations as it is. The SLP can help mother understand the importance of interaction and communication during feeding. So you don't want to be feeding the child and not interacting with them. You want to look at them, you want to talk to them, and smooth their head and interact, because that's early communication and communicative intent, establishment eye contact. Even when babies are born in the first 4 weeks, month of life, the distance, or maybe it's just 2 weeks, but the distance they can see is only the distance between breast to mother's eyes. So even physiologically, genetically, we're wired that child has that interaction between the mother and the child, and that you can see that mom and that baby within that certain amount of distance. When you get farther than that breast to eye distance, about a foot and a half, 2 feet, the baby doesn't see anything past that position, because that's how we were made in the wonderful design that we were made in. So that this is early communication here, and so it's very important that we utilize that time for that. So different feeding techniques, as particularly for these babies who are being breastfed, these are things that we can help them. But bottle fed as well, we can help with positioning. The premature baby may be placed in a flex position, which is the chin tucked down. So you remember in swallowing class how you learned that a chin tuck is an easier way to swallow than just the standard tuck, and that's how some of us like to swallow our pills, like that. So a flex position, chin tucked down into the neck, shoulders and arms pressed forward. It's a cuddling position, can aid in bonding as well as feeding. Also utilizing the boppy. I don't do anything without the boppy when it comes to feeding, because it just provides that stability. Whenever I don't have the boppy, his legs are falling down or his head's falling down or my arms are getting weak and tired. So that was the greatest invention ever. It's just a half moon circle pillow, and I'll bring it in here to show you. Okay, so here's the boppy, very convenient. Put it like that, hold the baby, and just wraps around the belly. Best invention ever. Highly encourage that for you future mothers in the group. All right, so it keeps the child Hall et al. Advocated for keeping the child's face near the feeders to encourage eye contact and social interaction. Trial and error may be necessary to find the best position. And so there are several positions that you can have them in. Again, that standard cradle, football hold, then lying down. I think there's one more position that I can't recall off the top of my head. Jaw stabilization, the mother can place her thumb or finger on the baby's chin just below the lower lip, another finger on and the temporomandibular joint, and a third finger under the chin. I think it's like this. Supports her to stabilize the head and jaw and to provide more control as the infant sucks. This control of the mother's part should be gradually faded as the infant's feeding skills develop. Negative resistance. So that is, as the infant pulls the nipple during sucking, the feeder gently tugs back. This often simulates a longer and stronger suck. Specialized feeding equipment. There are breast shields that are available. Nibbles of various characteristics. Flow rate, suction, compressions should be tried. I know when James was first born for bottles, we had to use the number 1 size. Versus now he's fine with any size, but anything beyond another 1, the flow was too great, and he would just get choked up on it. The nipple shield, it helps for inverted or flat nipples to pull that nipple out, and it's highly utilized. That they don't want you to use the nipple shield forever. They want you to eventually get away from the nipple shield and go to the general nipple. There's also they're not called shields, nipple shells, I believe is what they're called, that prior to breastfeeding, particularly number 1 to number 2, if you know that you have inverted nipples or flat nipples, you can wear these. They draw your nipples out between feedings or even prior to your milk coming in, so that you have the pointier nipples essentially that are more conducive to children feeding. You can modify temperature and consistency. James does not like anything cold at all. He will not take a cold bottle. He will not take cold food that's out of the refrigerator, nothing. And Kennedy and Cecile were not that way, so it's funny how each child's different. But that chilling liquids has been tried to increase swallowing rate and decrease pooling of liquid in the pharynx. But the main effect of this change may be to thicken the liquid, which makes it easier to swallow. So think about temperature and consistency. Formula could be thickened as well. Oral stimulation in feeding, so you can stroke the nipple on the side of the baby's cheek to elicit the rooting reflex, touching the nipple to the center of the lips and gum surface to produce mouth opening, allowing the baby to close on the nipple and start sucking, then stroking upward on the palate in a rhythmic motion with the nipple to encourage continued sucking. So you are essentially holding the breast, if you're breastfeeding, or holding the nipple and just pulling up to try to stroke the top of the palate. And same thing with the bottle. In the bottle, you're holding that and you pull up to try to instigate that sucking. So, and there's breastfeeding initially can sometimes be a team effort if you're not familiar with it. I know my mom helped a lot, and I stepped in to try to help my sister-in-law. You basically lose all modesty when it comes to that. When you're in the hospital and the lactation specialist comes in, just be prepared. They're going to grab everything and just go for it to try to get that baby to feed, because it's a learning process for the baby. It's a learning process for you. Once you have it, everything flows and feels natural. But you might come in with this expectation that this is just natural. Everybody does, and it's just going to happen, and we just know what to do, and we don't. So you as an SLP should be, if you're wishing to breastfeed your baby whenever that time comes in your life, you'll have a great knowledge and expertise in that because of your work in swallowing and with children. All right, and then finally, non-feeding oral stimulation. In addition to being encouraged to touch and stroke babies' bodies and NICU, mothers should be encouraged to provide gentle stimulation to the baby's face, rubbing it gently with fingers or soft toys, providing non-nutritive sucking, such as with the passy. So some oral stimulation activities are putting a finger nail down in the baby's mouth and rubbing the palate with an upper motion midsection to front to stimulate non-nutritive sucking, rhythmically stroking the midsection of the tongue front to back, like that, rubbing the infant's cheeks one at a time with a circular motion, tapping around the baby's lips in a complete circle, and placing a finger or toothbrush in the mouth and massaging the upper and lower gums. And these are all things I've done with my own children just to help stimulate them initially. Usually after we leave the hospital or after the first week, the rhythm's down. Again, with Kennedy, it took 2 weeks, who, by the way, had the short frenulum as well. It interfered with her latching on, And it took 2 weeks for her to get a good latch because we had to clip her tongue, and the pediatricians were not certified to do it. We had to take her to the ENT. So we had 2 weeks of a very difficult breastfeeding experience, and she got the tongue clipped, and everything was fine after that. And if I had seen it in the hospital, I would have, they could have clipped it there, but once she was discharged, we had to go to the ENT. They've since changed that policy within the hospital environment, and the pediatricians got certified for it. But it was definitely an interesting experience as a first-time mother, and it was something I've kicked myself as an SLP that I should have realized and recognized in the hospital environment, the heart-shaped tongue. Because remember how we know that they're heart-shaped when their frenulum limb's too short. And she was crying as I was changing her diaper, and I said, we need a tongue clip. And realized that was the primary interference with our sucking and latching on for breastfeeding. But so just word of advice, when you're an overwhelmed new mother, if that's a problem, think about that and look at that. Because you as an SLP knows that when I was that new mom, after birthing a 9-pound 1-ounce baby that was 10 hours of labor, I was not thinking in those terms, needless to say. All right. So oral motor feeding in pre-intentional infants and families. So this is ages 1 to 8 months. The same instruments, the standardized instruments used in the NICU are relevant for pre-intentional infant assessment, and the informal interviews as well that were listed in box 6.2. Around 6 months, new feeding patterns are acquired, which you can find in table 6.2. So you have liquids, purees, soft chewables, lumpy textures, all textures, more chewable foods, tougher solids. James is at purees right now. We started purees about 4 or 5 months. He's 6 months now. We haven't introduced soft chewables yet. He still needs to have a little bit more munching pattern in his behavior. And lumpy textures will be introduced later on. But sippy cups can be introduced at 6 to 9 months, as it says here, even sometimes earlier. Again, there's sometimes babies don't take the bottle at all and only will take a sippy cup. And the pediatrician also told me that even if a baby refuses bottle and sippy cup, if you say you go back to work and for a breastfed baby and they refuse all of those nutritional intakes, your body will still make up for the nutrition they need, and they get all that they need whenever you get home to feed them right away. But that's just not something you want to experience as a mother, and hopefully we won't. But we do know that our bodies produce the milk, and that it needs to give the child everything that they need, no matter how the child is eating. So that's pretty amazing. There's a lot of amazing things about breastfeeding when you really research it. So informal interviews, I did that. All right, around 6 months, you can see front to back movement of tongues. James is getting better than that with this, and I'm starting to see more front to back movement instead of the tongue thrust swallow, because he was a real bad tongue thrust swallow, again with that open mouth bite posture that he has currently. And then the rib up and down jaw movements as well. It's kind of a munching pattern, so I'm starting to see that. So I'll probably introduce the soft chewables within this month, month 7. There are specialized assessments for infants with traits or neurological involvement, but because of course they're not going to have the same mechanisms or in place that are necessary for swallowing. So a cervical osculation detects changes in upper aerodigestive tract sounds, and it's most non-invasive of these measures. Of course, the video fluoroscopic swallowing function studies. Those are what we all learn to do when we do our hospital internship, and they can be used to examine oral and pharyngeal movement during feeding and to assess risk for aspiration in children with neurological involvement. You have ultrasound studies, which allow for visualization of relations between movement patterns and oral pharyngeal structures. And then you have endoscopy, which involves passing a fiber optic tube through the mouth, down the esophagus, and into the stomach while the child is sedated. And of course, that's the most invasive, so we want to do that as one of our last measures. For evaluation of the GERD, the gastroesophageal reflux disease, there's the upper gastrointestinal study, which involves the child's ingesting a liquid containing barium that's visible on X-ray. This allows the radiologist to observe structural abnormalities or reflux into the esophagus. You have the milk scan, which is radioactively marked fluid. The radiologist sees where the marker fluid settles. If it's seen in the lungs, aspiration can be inferred. You have the radionuclide imaging studies or scintigraphy, which helps to quantify esophageal and gastric emptying and aspiration and provide multiple static images of concentrated regions of tracer residue over prolonged periods. There's the pH probe, which measures acidity by placing a nasogastric-like tube at the junction of the stomach and the esophagus. Just had a friend whose child did this. He vomits almost daily, and they think it's completely allergy related, that he's having such a severe allergic reaction that's causing him to vomit. But he's going through that. He had the tube inserted, had to wear it overnight from the hospital. So, ironically, the first cousin of the child whose friend has such severe GERD that she never took a bottle and went straight to sippy cup. So there seems to be some kind of genetic leak within that family with the severity of those the gastroesophageal regions and the types of feeding problems they experience. And then there's the methylene blue screening is used to determine whether a child with a trach is aspirating food into the lungs, which can lead to recurrent pneumonia. Food is dye, and evidence of emission of dye in the tracheal stoma, which would indicate aspiration, is monitored. So pH probe and gastroesophageal endoscopy are just considered the gold standards in the evaluation of feeding and swallowing. But hopefully we're not having to do that with the majority of infants that we're serving. But it is a possibility for those with more neurological issues going on. All right, vocal assessment. In this stage, we evaluate vocal ability. Now, figure 6.1 is a vocal assessment form, and you can see there's stage 1, 2, 3, 4, and 5 that covers vocalizations from birth to age 12 months. So you want to, when you're completing this assessment, you should consist of comfort state vocalizations. And that comfort state vocalizations are sounds the child makes in an alert and contented state and are typically heard during familiar caretaking routines, such as changing, feeding, bathing, or playing. And so you'll see in the videos that I've posted this week of James, there are 2 videos where he was on his changing pad, and he was talking to us. That's always been his favorite place to talk, is when I'm changing his diaper, because he has that direct eye-to-eye contact. One's when he's in his bumpo seat talking with his cousin, and one's when he is on the floor. I think my mother filmed that and gurgling a good bit, so he's on his play mat. So you can see those are all situations of the typical daily routine. He doesn't talk during bath, but he takes a pretty quick bath, and during feeding, he's usually focused on feeding. Usually 20 minutes is adequate to collect up to 70 vocalizations. The SLP observes the child and parent and listens to vocalizations. You're listening for intonational contours, pauses, or inhalation by the infant. Those are the types of vocalizations you're listening for. For vocal behaviors listed at the child's developmental level that are not observed directly, the clinician can demonstrate the behavior for the parent and ask whether the child ever produces that behavior. Crying with sudden pitch shifts, extremely high pitch, and that vocalization type of number 1, they just cry, and does the child ever cry like that? Just have a pitch shift. I'm demonstrating my own child's pitch shift cry. How can you tell if they're fussing or discomfort? Because in that early stage 1, the vocalization types are all directly related to crying and the different types of cries the child has. You can't, phonetically transcribe vocalizations that have consonant or vowel-like sounds. So that's in the phonetics comments column. The number of vocalizations produced in the time frame of the observation also can be recorded there. So how many of these did you observe? The stage at which at least one appropriate type of vocalization occurs is the state in which the child is emerging. So if this stage corresponds to the chronological age, the vocal development can be considered to be progressing adequately. And I'm going to show you that in a second with my next slide with the video. All right. One particular important benchmark to be aware of is the canonical babbling. Production of syllables that consist of one vowel-like element and one consonant-like element have sounds similar enough to speech to be described. So you saw that this week on the vocaldevelopment.com. Hopefully you've had a chance to learn and listen about vocalizations, the pre-canonical babbling, if it will play. My volume might be down. Okay. Here's canonical. ba, 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 ma, 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 ma. And then when you click on this, you can hear disyllables, consonant vowel symbols, babbling, whispered vocalizations. So I like that this is more detailed when you get to the examples first. Full and quasi-resonant nuclei. Vocants. Vowel clad squeals. James loves squeal. Marginal babbling. So you can start to hear some intonational changes there in that marginal babbling. So do go through those. And here's the advanced forms. CVC. Jargon. Diphthongs. So James is not here yet. Obviously, it's 10 to 18 months. He's demonstrating. Well, I'll let y'all decide what stage he's in and what he's demonstrating based on these examples. Okay, so that's a very important transition, though, to early speech. That ma, ba, 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 da, 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 da. Other important features to note in child's babbling are the rate of vocalization, which should increase with age, the proportion of consonants to vowels, that should also increase with age, multisyllabic babbling, which should increase with age and appear by end of the first year. At the end of the first year, the infant should imitate intonation and contour of ambient language and the melody of sentences. Okay, so here we have James. This was recorded April 9th, 2016. So he is December, January, February, March. He's 4 months old, about 10 days from turning 5 months. And he is showing pre-intentional vocal behavior. So for your reference, look at figure 6.1 on page 195. We know he's either going to be in stage 2 or stage 3. But based on his age, that's where he should be developing. Nope, I don't want to do that. If it will play. Sorry. Okay, and I think I was trying to get him to laugh, or Kennedy was, and so it is pre-canonical, and I would call that, I think this one. Nope. It's either vocants or marginal babbling. Yeah. So that's what I think he's demonstrating is marginal babbling, which is appropriate for his age. Again, birth to 6 months. He was 4 months old. So vowel sounds predominate, but a few consonants emerge, primarily velars, and glottals. And you can hear in that video that he's going, oops. So you can see there's kind of some glottalization there at the back. That that's one of his favorite sounds too. And since very early on, he's been doing that. He loves those glottal sounds. And he marked decrease in crying. Yes, we saw that. Begins consonant plus vowel, mostly coo and goo, which you did not observe in that video, but I can say he did goo a good bit. Begins to produce pleasure sounds such as that he wasn't producing but he does have pleasure sounds. So as a parent, I'm reporting to you that he has achieved all of the areas of stage 2 at 4 months. And you could almost say that the imitation of sounds and back and forth babbling games with others, because Kennedy and he are conversing, that he's doing that more variations of vowel production. And laughter. Again, I was trying to get a good video of him laughing. I actually have one very, very much earlier of him laughing than this 4-month video. and raspberries. He definitely is doing that now. I think he was doing it then. Pinch contours, we definitely observed that. Extreme pitch glide, such as yells, squeals, and low pitch growls. So I did observe that. So he has passed stage 3 too at the time of this video, or right in the midst of that stage 3. Now he's past stage 3, in my opinion. All right. Now here's another video. Well, let me see if I can. Example of an imitation, intonation, contour speech.
Do you remember who was all there? Luke and Chloe?
Oh, that sounded like banana.
You might need to breathe, girl.
And well, you didn't even play with your own toy. Okay, I played with everybody else's toys.
Good.
All of Luke's toys.
Hot potato, hot potato, hot potato, hot potato. Rest, so she's good for a while. Does that mean you want hot potato? Hot potato, hot potato, 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 potato.
So, not only did that video provide you with a smile for the day, but it also had a great demonstration of that imitation of intonation of contour speech, that she was mimicking the melody and prosodic contour of sentences. You can also see interaction between she and her parents, both her father and her mother behind the camera. She's making eye contact, joint attention, and engaging and conversing with them. So that child, I don't know how old she was in that video. I'm guessing around 12, 14 months. She is just precious, and she demonstrates that intonation of contour speech. Okay, so that is the pre-intentional stage. Managing feeding and pre-intentional, the same strategies for NICU babies can be used to improve sucking and feeding here, so I'm not going to divulge that much more of my personal breastfeeding experience with y'all today. That includes oral stimulation, non-nutritive sucking, and presentation of safe items for babies to mouth. Feeding with solid foods can be introduced around 6 months if assessment indicates this is safe. Children with craniofacial anomalies and depressed muscle tone may have difficulty with this transition. Children with Down syndrome might have difficulty. They might be delayed more than 6 months. So box 6.3 gives some great suggestions for improving feeding skills. Sit below the baby's eye level to feed. Start with single consistency foods. Vary texture gradually. Start with unheated food. Tap the lip or tongue to alert the child prior to going in. Present small amounts of food on the spoon in early spoon feeding. Minimize spoon to teeth jaw stimulation. If the child bites the spoon, wait. Avoid constant face wiping, because they wipe their face and they go, oh, they don't want you to do that because they just want to get the food in. So you just deal with the mess and you clean it up when they get finished. And like with James, I have to keep feeding him over and over again. Like the minute he swallows, he wants more. He's a very quick eater, and he doesn't, if I pause, if I slow down, he squeals at me because he is hungry and he wants to eat, and he wants to eat it all in one fell swoop. It's funny. You want to identify their preferred tastes. Finding the foods they like may be more important than a balanced diet in the early stage. I've had green beans fit on me from James. He does not like them. He likes avocado, bananas, apples, things that are sweet, peas, carrots, sweet potatoes, squash, but no green beans. Present a bite of a new or seldom eaten food between bites of favorite foods. And sometimes I've had to mix prunes with his cereal or mix prunes with something else, kind of disguise it because he needs that for nutritionally speaking, but he doesn't like it. Mix a small amount of new food in with a favorite food. Improve chewing. Use crunchy foods such as dry cereal, crackers, and cookies when they're ready. Place food directly between gums and molars. Cut food into strips. Wrap cooked meat or fruit in gauze attached to a string. I've never done that. It makes me a little nervous, but I'm sure with our expertise, it would be fine. Place finger food on the center of the tongue and place a cup on the baby's lower lip. So those are all strategies we can utilize. And you can also use the same resources that were listed in the NICU section for the pre-intentional baby and managing their feeding. So managing vocal development in the pre-intentional baby. So if vocal behavior appears to be lagging, hearing should be assessed primarily. That's the first thing we need to assess to make sure the child's hearing. So you assess their hearing fine. So that needs to be addressed as a therapeutic goal. Encouraging vocalization should be a part of the intervention plan. The family should talk and babble with the baby, to the baby, have that interaction. If I was watching that video I just showed you on YouTube with those parents, I would not have anything to advise them to do more than what they're doing already, because they had great interaction with their child and were really responding to what she was saying and acting like she was talking to them, even though we really couldn't understand what she was saying. And how she would do that sign language, hot potato, and Dad said, "Oh, you want hot potato?" She may or may not intend that, but that is what he's taking as her intention. So intention is very critical there. You want to choose targets from vocal assessment that child is not demonstrating. So going back to that chart, if there's something in stage 3 for a child who's 4 to 6 months that they're not demonstrating, you choose that target. Maybe it's around the front sounds like raspberries. So you would demonstrate raspberries, bilabial trills, lip smack. And usually if that child's watching you, they'll try to do something like that. Or when the child does it, you imitate it back to them. When caregivers coordinate behavior with infant babbling, the rate of vocalization increases and more advanced vocalizations are observed. And that's what the research has shown. Use rattles, tickling games, and mirrors to elicit vocalization, anything that engages that behavior. SLP can teach baby talk register through modeling. Now, baby talk, also known as motherese, high-pitched speech, we go up highly to say, "Oh, you're so cute," and exaggerate intonation. "Oh, the sweet boy. Who's so sweet? He's a sweet boy. He's a sweet boy." Simple words and short, repetitive sentences like "he's a sweet boy." You can tell I do this a lot right now. All right, oral motor and feeding in prelinguistic children, ages 9 to 18 months. So this is the last we'll talk about oral motor and feeding in this section, and then we'll talk about the linguistic child, which is 18 months and beyond, when we get to chapter 7. Difficulties in feeding may result from neuromotor involvement, so we need to ensure that if that's what's causing it, that we've considered all of the medical factors there. Again, you can use the same strategies as before, what was listed in box 6.3, and then in appendix 6.6, it lists some more strategies for feeding. So you can find that on page 228. It talks about food choice, equipment for feeding, positioning for children with their feeding, developing cup drinking skills, developing spoon feeding skills, chewing skills, and cautions. And pay special attention to the cautions. It talks about tongue thrust, tongue retraction, jaw thrust, lip retraction, lip pursing, tongue bite reflex, jaw clenching. And like I said, James was doing a tongue thrust. He's not doing it anymore, at least not the protruding tongue thrust. He might still be tongue thrusting a little bit when he's swallowing, but you can see initially when they begin feeding that their motoric system is not necessarily wired for that yet, so they're not swallowing as they should be, but as they grow and develop, you should see that progression move more towards that typical swallowing pattern. That's what you're looking for in your children. So those are your cautions there and your considerations in feeding older children. Before initiating a feeding program, again, associated medical problems must be addressed. We must make sure that all those components are taken care of in the child. For your evaluation, you want a review of the medical, developmental, and feeding history, a physical examination, a pre-feeding assessment, so what they can and cannot chew or swallow or suck, directive services of chewing, biting, swallowing, and interactions during feeding, assessment of food preferences, and a decision whether to apply an instrumental assessment, such as some of those instruments we talked about before, the video fluoroscopic examination, the endoscopies, and whatnot. All right, yeah, sorry, I was trying to find my place in the book. All right, feeding issues can be addressed with behavioral approaches, such as a new skill acquisition, generalization, and reinforcement. Parents need to understand feeding is functional and social. So remember, when we sit down at the dinner table, we're actually socializing and communicating with each other as well as fulfilling that need to eat. So we don't want eating to be very mechanical, and because if not, they won't develop that awareness that feeding should be for pleasure and enjoyable. So you want parents to give lots of praise and verbal encouragement, speak to children during feeding, be careful to time remarks so that they don't excite abnormal patterns of chewing or swallowing. And even talks about for older children, lunch clubs in the cafeteria for children with special feeding problems where they can invite friends to a table. For those children with the feeding problems, they have a special table. So if somebody gets invited to that table, then that's special for that child who doesn't have those swallowing issues. And you also, as always, need to be culturally sensitive and aware of the attitudes of families about feeding. So, they might eat with their fingers in some cultures, or they might not talk dinner for some cultures. So being aware of how that their family views it. So oral motor skills used in feeding are necessary but not sufficient to develop speech. Speech must be addressed directly because swallowing is a vegetative state, and speech is a voluntary functioning, a voluntary mechanism. Developing oral motor skills through feeding is important because eating is important, but it will not guarantee these skills will generalize to speech. So there's a lot of research about the use of non-speech oral motor activities to increase speech production and speech intelligibility, and there's not a lot of evidence to support that non-speech oral motor exercises work. So this is directly tying to that. And non-speech oral motor exercises are necessary early on to initiate swallowing things. If it's related to swallowing, it's valid. If it's related to speech and increasing speech production, there's not a conclusive tie that non-speech oral motor activities increase your speech intelligibility. Speech must be addressed directly within the goals. So you want to develop the goals as part of the intervention program. Vocal production should be explicit in the intervention program. You want to use similar techniques for parents to stimulate canonical syllables. You want to work on expanding consonant repertoires, so giving them more consonants. And then box 6 has suggestions for facilitating constant production in early speech. And to increase length and rhythm production, engage the child in similar repetitive motor activities. Ba 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 ba, me, ba 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 ba, mama, bama, bama, bama. Eventually add words, go, jump. So you just want a lot of that early syllable playing initially. You don't want to go straight to words for these children when you're trying to develop that with the parents. To connect sounds of meeting, teach songs, wheels on the bus. Even if they're going, wheels on the bus go, wow, 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 whoosh, 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 whoosh. Encourage expression of emotion with conventional vocalizations. Like, wow, uh-oh. Over exaggeration so that they can make associations between those sounds and those feelings and those words. Use stress syllables to facilitate consonant production. Baby to facilitate b. Use velar consonants to facilitate closed syllables. Introduce alveolar consonants before a front vowel. T to facilitate T, or T to facilitate T, sorry. To facilitate production of a consonant and new place of articulation. Use a word that contains another consonant at the same place of articulation. Toss to facilitate S. So you want to keep in mind your speech production and the influence of the surrounding phonemes there. And then use words with fricatives between vowels, taffy to facilitate, to elicit first fricatives. So those are all strategies that you can use. The frequency, volume, and maturity of vocal production should be addressed even with AAC users. And then, again, there are the considerations in feeding for prelinguistic children and Appendix 6.6. And that concludes Module 2, oral feeding and vocal development in the infant, pre-intentional, and pre-linguistic child. We will discuss oral motor feeding and vocal and phonological development for linguistic children ages 18 months older when we get to a later module.